The topic is efficacy and safety of Amplatzer Vascular Plug Type 4 for embolization of pulmonary arteriovenous malformation. I'm Sang-Yub Lee from Kyungpook National University Hospital in Korea. Pulmonary arteriovenous malformations represent direct communication between the pulmonary artery and vein. Endovascular embolization is the treatment of choice for a PAVM to prevent stroke or brain abscess. Various embolic materials have been used for embolization. These include pushable stainless and platinum coils, detachable balloons, detachable coils, and, most recently, nitinol vascular occluders, such as the Amplatzer Vascular Plugs. AVP has less migration potential and can be repositioned after final placement. Previous studies showed about 7 to 57% recanalization rate in coil embolization. In contrast, type 1 and 2 AVPs showed lower recanalization than coil embolization. However, a large diameter delivery sheath or guiding catheter is needed, so it is difficult to use type 1 and 2 AVPs, especially in an angulated feeding artery with a small diameter. The smaller type 4 AVP, AVP4, has been introduced to address these problems. Its diameter is 4 to 8 millimeters, and it can be delivered with a 5F or 4F diagnostic catheter. There is only one small study using the AVP4 for PAVMs. It showed zero recanalization according to 30% SAC reduction criteria. AVP4 has diverse merits, including its small size, shorter procedure time than coiling, and less migration potential than coiling. However, general results about safety and efficacy remain unclear. Therefore, the purpose of this study was to provide more evidence about the safety and efficacy of the AVP4 for PAVM treatment. Between June 2013 and January 2018, 13 patients with 26 PAVMs were treated with the 64 AVP4 embolization. 4 patients without follow-up computed tomography CT were excluded. In conclusion, 9 patients with 19 PAVMs were included. This table shows demographics and number of treated PAVMs in our study. We used a 6F guiding catheter for guidance and a 5F hydrophilic catheter with a side hole for selective catheterization of the feeding artery. The AVP4 was delivered with a 5F catheter and was deployed near the sac. After plug deployment, we confirmed vessel occlusion by using completion digital subtraction angiography. In imaging analysis, pre-procedural CT was used to determine the type of PAVM. And feeding artery, sac, and draining vein diameters were measured on pre- and post-procedural CT. Also, we measured plug to sac distance on angiographic images. Technical success was defined as complete occlusion of the sac and draining veins on completion angiography. In the results, the most common type was a simple PAVM. Mean procedure time was about 29 minutes. Technical success was 100%, and successful embolization was 87% according to 70% SAC regression criteria. 74% showed complete venous sac regression. Feeding artery size decreased in all patients. There were 2 minor complications. including chest discomfort and tachycardia. However, all symptoms spontaneously disappeared. We had 3 failed treatments, which showed less than 70% venous sac regression on follow-up CT. They showed 43, 51, and 63% of venous sac regression. This is an example of a failed treatment. The sac reduction rate was 51%, and the feeding artery reduction rate was 25%. Right upper lobe, n equals 1. Right middle lobe, n equals 6. Right lower lobe, n equals 6. And left lower lobe, n equals 6. 2 lesions were complex, 2 feeders with a single draining vein. The remaining 89% were all single-type PAVM. Mean feeding artery size was 3.1 millimeters, plus or minus 0.7, with a range of 2.1 to 4.9 millimeters. This case is a 50-year-old female who had multiple pulmonary AVMs. The left one is a simple PAVM, and the right one is a complex PAVM. After treatment, CT showed no feeding arteries or draining veins. This is another successful treatment case. CT showed complete regression of the venous sac and decreased size of the feeding artery. AVP4 has various advantages in comparison to previous embolic devices. It can be introduced with a smaller caliber catheter. It has less metallic artifacts than coil embolization on follow-up CT. And it has a relatively shorter procedure time. And it may also contribute to a reduction in radiation exposure. This table shows a comparison of previous studies with the same 70% SAC regression criteria. Recently, Stein et al. Published coil embolization of small PAVMs. They showed a 79% success rate. However, AVP4 has drawbacks. First, it cannot be used in a large diameter feeding artery. The AVP4 is appropriate for vessels 6 millimeters in diameter or less. Second, if the feeding artery is small in diameter or shows an acute angulation, it may be difficult to position the catheter to the target site near the nidus. The present study has some limitations, including a small number of cases and a short follow-up. There were some lost cases, and plug to sac distance was measured on angiographic images. Also, the entire procedure time was not comparable to other studies. In the present study, the AVP4 shows an excellent technical success rate and no recanalization. The AVP4 has diverse merits, including low migration potential, low profile allowing for easy delivery, and a higher occlusion rate than other embolic devices for the treatment of small, less than 6 millimeter PAVMs. Thank you for your attention.